Okay, so for today, we will be discussing the last topic for immunology and serology, and that is the serologic and molecular detections of viral infections. So this is such a vast topic, and that is the reason why we will be including in another lecture HIV and COVID-19. So the coverage of today's lecture would be the review of the virus structure and life cycle, the immune defense against viruses, the viral escape mechanisms, laboratory testings for viral infection. So I would only be including these viruses for today's discussion: hepatitis viruses, herpes viruses, and other viral infections. And then we will have a separate lecture for HIV and SARS-CoV-2. So that will be covered by another lecture. Okay, so let us discuss virus. Okay, so viruses are considered to be as an obligate intracellular parasite. And the reason why we say that they are obligate intracellular parasite is because of the fact that they cannot live outside the host cells. They need to use the genetic machinery of the host, okay, in order for them to survive. Okay, so these particular viruses are also known as filterable agents. And the reason why we call them filterable agents is because of the fact that they are able to pass through bacteriologic filters. So viruses are able to pass through bacteriologic filters. That's the reason why we call them filterable agents. Now, one of the things that you have to remember about these viruses is that they are too small for us to see them or to observe them using an ordinary light microscope. Unlike bacteria, we can gram stain them and then observe them under oil immersion objective. But for the viruses, they are too small for us to observe them under ordinary light microscope. Also, it is quite difficult to culture viruses. Unlike bacteria, we can easily culture bacteria using synthetic culture media. Like say, for example, we can culture bacteria in blood agar plate, but for viruses, it is quite challenging. And that is the reason why a molecular and serologic diagnosis of viruses would be very important. Now, as to the life cycle, there are two types of life cycle. So, depende if it's a DNA virus or the RNA virus. Usually, DNA virus life cycle happens in the nucleus of the cell, of the host cell, whereas the RNA viruses would happen at the life cycle would happen, or the replication would happen at the cytoplasm of the host cell. Okay? And viruses may be classified whether it is a DNA or RNA. So remember, a single virus couldn't possibly have two nucleic acids, unlike the prokaryote, unlike the eukaryote. These particular living organisms could have both nucleic acids. But for the viruses could only have viral DNA or viral RNA, but never both. Okay, so what are the parts of the viruses? So we have the envelope and the envelope proteins. Okay, so the envelope is not viral coded. So it is not viral coded. So it is actually the lipid plasma membrane that buds off from host cell. So during the process of budding, so we call it budding, viruses, whenever they escape the host cell, will utilize the cell membrane of the host cell to become its envelope. So that's the reason why it is actually more of a lipid layer. Now, the envelope protein, sometimes they call it the spike glycoproteins, are actually seen, okay, near the envelope, and they are very important, particularly for viral penetration. So what is viral penetration? So whenever the viruses would try to enter the host cell, okay, so the spike glycoproteins would have a receptor site to the host cell, okay, and that particular glycoproteins will allow the nucleic acid or the capsid, okay, to enter. So by the way, the capsid plus the nucleic acid, particularly this particular layer, is known as the core. So what are the receptor sites? So for example, CD4 or the T helper cell, okay, uh, is the receptor site of the HIV, particularly the CXCR4 and the CCR5. Okay, so this will bind to the this will actually this particular this particular receptor sites will allow the virus this particular receptor sites would allow the virus to bind with HIV, thus allowing the virus to enter the host cell. Okay, now let's talk about the capsid. Capsid is actually the source of antigen. So it is source of antigen, meaning to say it is highly antigenic. So capsid is actually made up of proteins. If we're going to dissect or to look or to magnify this layer, it is made up of a protein subunit in beads. And this particular protein subunit in beads, they are known as the capsomer. Okay, so the capsomer is the protein subunit. Okay, and then this is the nucleic acid. Okay, nucleic acid, which could either be DNA or RNA, they are important for viral infectivity. Okay, so these are important for viral infectivity. Okay, so there you have it in one slide, the structure of the basic structure of a virus. By the way, a complete viral particle that is infectious already, we call it virion. Okay, a virion is a complete viral particle that is infectious already. Okay, so I think I have already discussed this one. So they are obligate intracellular pathogens, okay, which rely on host cells for their replication and survival, and they are present as freely circulating particles and intracellular particles. So again, if you notice, these are the basic steps in the life cycle. So this is an example of how a viral or an envelope viral envelope or envelope viruses life cycle. So the first step is attachment. So as you can see in the attachment, the envelope will be left outside the cell, and only the and after the penetration, the next step is uncoating, meaning to say the nucleic acid. The nucleic acid will go out of the capsid, and the nucleic acid of the virus will enter now the nucleus of the host cell. Why nucleus? Because it is an enveloped virus. So take note, if the virus is non-enveloped, the replication will simply happen in the cytoplasm. So the next step would be transcription, translation. What does it mean? In this particular life cycle, the virus will now use the genetic machinery of the host cell in order for them to allow protein synthesis. This will allow protein synthesis so that they will be able to produce proteins. And these proteins are not useful for the host cell, but these proteins are needed in order to produce more viruses. And after these proteins are assembled, they would be after these proteins are produced, they will be assembled. Okay, so it's called viral assembly. And finally, they are ready to go out of the host cell. However, since they are enveloped, we have a process known as budding. In budding, the virion will now utilize the cell membrane of the host cell. And if you notice, no, the cell membrane becomes the envelope of the virus. That's why I told you a while ago that the envelope of the virus is not virus coded. It's not virus coded. Okay? So that is the life cycle of the virus. Are we defenseless against viruses? Of course not. We are not defenseless. We have our innate defenses. This is the natural immunity. We have already discussed this, but I'd like to give emphasis. I go back to ayan. I'd like to give emphasis on interferons. Interferons is a natural defense that has antiviral nature. Okay, so it's part of our natural defense. And then aside from that, we have specific immunity. Specific, or sometimes known as the adaptive immunity. And speaking of specific and adaptive immunity, there are actually two. So we have the humoral response, and the other one is the cell-mediated immunity. Okay, so what's the difference? So again, when you say humoral immunity, this is about the production of antibodies by plasma cells. So plasma cells will be producing antibodies, and it will attack free viruses. What do you mean by free viruses? Free viruses means that the virus is still outside the host cells. Or it could also mean that the viruses are in circulation. Okay? So this can be manifested through viral neutralization, opsonization, complement fixation, and antibody dependent cell cytolysis. Okay, and then the cell-mediated immunity, okay, is actually destruction of target cells. So again, when you say target cells in this particular context, we are referring to virally infected cells, meaning to say the viruses are already inside the host cells. Okay, so this can be achieved through gamma interferon and production of different cytokines such as interleukin 2. So the cytotoxic T lymphocytes will be destroying the target cells. So one particular mechanism, if you could still remember our discussion during the prelims, is the perforin granzyme. perforin granzyme mechanisms that will lead to the destruction of the target cells or those cells that are virally infected. So in a nutshell, um, this is how we illustrate it. Okay, so this is the humoral response, the neutralization of the virus through the production of antibodies. Okay, so this one is part of the destruction of the target cells by the cell-mediated immunity. And this one here are the part of the natural immunity. This is the cell-mediated immunity. Okay. However, despite of the fact that we have a very concrete mechanism in fighting these viruses can still escape our immune system. Okay, how is it possible? Number one is through mutation that will result in the production of new viral antigen. And this one is very common, particularly for influenza. So do you know that influenza or the orthomyxovirus is made up of 8 segmented RNA. And because it is made up of 8 segmented RNA, this one is very prone to mutations. And there are 2 major types of mutations for influenza. Okay, the first one is known as the antigenic shift. Okay, so when you say antigenic shift, it is the major antigenic changes. So for example, the development of H1N1 or the development of H5N1. So these are examples of major antigenic changes. Okay, these particular major antigenic changes can result to pandemic. The last pandemic of H1N1 happens in 2009. However, it wasn't as severe as the current pandemic, okay, because of the antigenic changes. So we call it antigenic shift, okay? And the other one is antigenic drift. We call it antigenic drift. And antigenic drift is minor antigenic changes that can result to just local epidemics. Okay, and this is the reason why we should have the annual flu vaccines. Okay, annual flu vaccines because of the antigenic drift. Okay, that can result to minor antigenic changes. Okay, now the second reason is the viruses could block the action of immune system component. So particularly the hepatitis C virus can block the C3b. Okay, and C3, as we all know, is a major component of a complement. Okay, number 3, suppression of the immune response. So cytomegalovirus could reduce the MHC1 expression. Okay, so that's one way of having a viral escape mechanism. Okay, number 4 is the latency. Latent state is established. So these particular viruses could remain latent. Okay, so when you say latent, they can hide, okay, in nerve cells. They can hide in nerve cells. Example, chickenpox is a varicella virus. And then this varicella virus could hide. And when they reappear, they become shingles. And shingles is a latent infection of chickenpox. So when they are hiding, inside one of our cells, we call it the latent period. Okay, so latency. And that is actually seen not just in chickenpox. For example, in Epstein-Barr virus or EBV, B cells, they would be the site of latency. Or, okay, so that is one of the characteristics of these particular viruses. By the way, Epstein-Barr virus, varicella virus, both of them belongs to herpes viridae, one of the largest family of DNA viruses. Okay, so how do we test for viral infection? So this is where immunology and serology will come in. Okay, so the first type of test that we could actually do is to perform serologic testing. So basically speaking, when you say serologic testing, we are referring to antibody testing. And when we say antibody testing, this will allow us to distinguish between the current and past infection. So remember, IgM is known as the primary response. And then IgG is known as the secondary response. So IgM is a primary response, and then IgG is a secondary response. What does it mean? It means that if a person is positive with IgM and would have a variable result in IgG, it would mean that there could be a current or recent infections, okay, or congenital infection. However, it's quite difficult to assess congenital infection since neonates will not be able to produce its own antibody. So that's the reason why it may not be valuable for neonate with cytomegalovirus infection. Okay, now another one. If a person is negative with IgM but positive with IgG, then this means that there is a past infection. Okay, so what is the importance of serologic testing? Now, one way to monitor the course of infection is to determine the antibody titer. Why? Because the antibody titer is directly proportional to the antibody concentration. And a significant antibody titer is whenever there is a four-fold increase between the first test and the second test. So, for example, during the first test, the dilution is 1:4, or the titer is 4. And then during the second test, the dilution where the patient becomes positive is 1:16, or the titer is 16. So this one is already considered as a four-fold increase. So that one is already considered as a four-fold increase since 16/4 is equivalent to 4. Okay, so that is the reason why it is already considered as a four-fold increase. Okay, so that's the importance of performing the antibody titer. And lastly, serologic testing will assess the immune status of the infection, particularly if the patient becomes positive with IgG, because if the patient becomes positive with IgG, this means that the patient is already in the course for recovery or has been infected in the past. Okay. The molecular test, on the other hand, will detect active infection. Okay, so it will detect active infection, and molecular tests will allow us to do the quantitative test, particularly if we are doing the qPCR or the quantitative PCR or the real-time PCR. So it can assess the immune status also. Okay? So let us discuss now the different types of viral infections. And let's start with hepatitis. Okay. Do you know that the currently established hepatitis is A, B, C, D, and E? And they're proposing that there is the hepatitis G. So let us discuss first the two main types of hepatitis. There are those that are transmitted by the fecal oral route. Okay? And these are hepatitis A viruses and hepatitis E viruses. Okay. Hepatitis A is known as the infectious hepatitis, whereas the hepatitis E is known as the waterborne hepatitis. Okay. There are those hepatitis that are transmitted through the parenteral route. So these are the hepatitis B virus, the hepatitis D virus, and the hepatitis C virus. Okay? So what are the nicknames? So hepatitis B virus is known as the serum hepatitis. Okay, hepatitis D virus is known as the delta hepatitis because it is caused by delta viruses. And hepatitis C virus is known as the post transfusion hepatitis, the post transfusion hepatitis, or the post transfusion hepatitis, or it is known as the non-A, non-B virus, because at the start they thought that there are only two types of hepatitis, hepatitis A and hepatitis B. Okay, so let's what are the clinical and laboratory findings? Usually, there is a general flu-like symptoms at the early infection, and patient will feel pain at the upper right quadrant of the abdomen. So obviously, there would be hepatomegaly, or when you say hepatomegaly, we are referring to the enlargement of the liver, and that is also accompanied by liver tenderness with progression. There is jaundice. Jaundice is characterized by yellow discoloration of the skin and the sclera. There would be dark urine and light feces, light colored feces. Okay. And there would be elevated bilirubin and liver enzymes. I hope you are already familiar with the normal range of your B1 and B2 and the different liver markers that can be utilized to assess hepatitis. Okay, let's discuss them one by one. Hepatitis A is an example of an RNA virus. So this belongs to one of the smallest but largest in terms of members. Okay, one of the smallest in terms of size, and that is the Picornaviridae. Okay, so hepatitis A belongs to the Picornaviridae, but the actual virus that causes hepatitis A is known as the enterovirus. Okay, enterovirus. So it is transmitted through the fecal oral route, close person to person contact. Because these particular people, if they are in close contact with one another would tend to share food and water. And of course, since it is fecal oral route, you would expect that you can get hepatitis A through ingestion of contaminated food or water. So hepatitis A would produce acute hepatitis in majority of adults, and infections in children are usually asymptomatic. So the average incubation period is 28 days. So as you can see, um, after the incubation period, um, in less than a week, fecal HAV will increase, and then you'll be positive also with the stool hepatitis A, and that will be characterized by symptoms such as jaundice. Okay, so acute infection is indicated by being positive with IgM anti-HAV. So this is the titer, the peak. Okay, and then eventually immunity is indicated by being positive with total anti-HAV along with IgM anti-HAV. So if you are positive with IgM anti-HAV, that's also a good sign. Okay, because negative pala, sorry, you have to be negative with anti-HAV. This one is going down, and then the yellow marker here is the IgG. We need the IgG to increase in terms of the titer in order to affirm that immunity is slowly but surely being established by the infected patient. Is there a vaccine? Yes, there is a vaccine for this one, particularly if you will be visiting countries that are endemic with hepatitis A, usually in third world countries. So the vaccine is a formalin inactivated hepatitis A vaccine. Okay. However, for those people who were not vaccinated but has already been exposed to hepatitis, then they should be receiving the HAV immune globulin. Okay, so that is for hepatitis A. So let us um, summarize hepatitis A. So it is the virus is hepatitis A virus. Okay, so this is under the enterovirus, and the family is Picornaviridae. The transmission is primarily through oral fecal route. It will not progress into a chronic state, and the complication for fulminant hepatitis is very low. What do you mean by fulminant hepatitis? This is a complete destruction of hepatocytes or liver cells. The serologic markers are IgM, anti-HAV, total anti-HAV, and HAV RNA. So HAV RNA can be measured quantitatively through RT-PCR. Okay? And clinical significance, it can cause acute hepatitis A or the infectious hepatitis. So we can detect hepatitis A virus. We can isolate them from clinical samples, from food or water. So when we say clinical samples, these are mainly feces. Okay? So that is the hepatitis A virus. Okay, so moving on, let's now discuss hepatitis E virus from Hepiviridae. So the transmission is also through oral and fecal route, and it is one of the major causes of hepatitis worldwide. So there are 4 genotypes, HEV1 and 2, and it is ingestion of feces contaminated drinking water. So these two are known as the waterborne hepatitis. HAV3 and HAV4 is transmitted through zoonotic infection, particularly through pigs. Okay, so it is a type of zoonosis. Okay, so majority of the patients are asymptomatic and the infection is self-limiting. So vaccines may be utilized to prevent the infection, and severe infection is possible for pregnant women and for immunocompromised persons or those persons or people with debilitated immune system. Okay, so the serologic markers, okay, we can detect if there is an acute infection if a person is positive with IgM anti-HEV. So this is now the first marker. Now the second marker is the IgG anti-HEV, which would indicate past exposure. So if you will be looking at the graph, okay, by the way, the molecular diagnosis is to detect the HEV RNA. So HEV RNA can be detected either in blood or in stool samples coming from the patients who are suffering from acute infection. Now, as you can see, okay, the period is the period of infection with hepatitis E is divided into 4. Okay, so we have the incubation period, the prodrome period, the icteric phase, and then the convalescent. Okay, let me discuss it now. So when you say convalescent, it means that you are in the road to recovery. Okay. So the prodrome period is the period between the is in between the incubation period and icteric phase. What do you mean by icteric phase? Icteric, diba, when you say if the serum is icteric, it means that you would expect that the patient would be having a liver disease or there is already a jaundice. So an icteric serum, so yung serum is instead of being light yellow, becomes dark yellow na papunta na sa orange or red. Hindi naman yung red na hemolyzed, but yon. So that's how we describe an icteric sample, no? So icteric phase. Okay, so ito na yung mga patient na mayroong jaundice. But before that, before the appearance of the sign and symptoms, there is a period wherein the patients are asymptomatic and you cannot totally detect anything, perhaps because the patient is still in incubation period. Okay, so during the prodrome stage, this is where the HEV RNA would be at the highest peak. And right after the icteric phase, one of the markers would be at the highest peak, and that is the ALP, also known as the SGPT. That is one of our liver enzyme, serum glutamate pyruvate transferase. Okay, so this particular liver enzyme would be at highest peak during the icteric phase. So the first antibody that would appear is the IgM anti-HEB. Approximately during the 6th week, it would be at the highest peak. And then the IgG would be the highest peak during approximately at the 7th week. Okay, so these are the markers that we are using for hepatitis E. Okay, so in summary, hepatitis virus, the etiologic agent is hepatitis E virus, and they belong to Hepiviridae family. The primordial mode of transmission is fecal oral route, and progression to chronic state is possible, especially among immunocompromised individuals. And the complications would be a fulminant liver failure, and it is quite dangerous and for pregnant women, so they are more vulnerable to get a fulminant liver disease. So serologic markers includes the IgM anti-HEV for acute infection, IgG anti-HEV to assess past infection. HEV RNA is also used for quantitative studies. By the way, why do you think quantitative studies are important? Quantitative studies are important because this will assess viremia. So when you say viremia, this is the viral load, the blood viral load. The higher the viremia, if the viremia level is high, the prognostic index or the chances of recovery, known as the prognostic index, would be very low. And viremia can be assessed through quantitative HEV RNA through PCR. Okay, through qPCR, quantitative PCR. Okay, so let's talk about hepatitis B. Hepatitis B, or the serum hepatitis, is the major cause of morbidity and mortality all throughout the world. Okay, and it is a DNA virus. Okay, particularly known as the Hepatnaviridae. So they belong to the family known as the Hepatnaviridae, which is transmitted through parenteral or the perinatal routes. Okay, so what are examples of perinatal? So when you say perinatal, it is usually through intrauterine or during childbirth. Okay, or whenever the infant or the neonate is breastfeeding, is having milk to breastfeeding. Okay, so perinatal is an example, therefore, of vertical transmission. But for parenteral is an example of horizontal transmission. And there are two types of horizontal or parenteral transmission, either through sexual intercourse, that is sexually transmitted, and the other one, not two types, there are actually four types, no, of horizontal transmission: sexually transmitted. Number two is when you get hepatitis B through blood transmission. Okay. Number three is when you use non-sterile instrument. So for example, during dental procedures or during body piercing, during tattooing, during even a simple process such as pedicure or manicure. Okay. Number four, this one is very rare, huh? Through wounds, insect bites, and animals. Wow, can you imagine? You can also get hepatitis B, though that is very rare. Number five, this one is very common for medtechs. Not really common, but we are more prone to get it. Use of non-sterile syringe. Through, paano ba tayo ma-infect? It could be through accidental needle stick. So you do not want to prick yourself. Okay? Or through intravenous drug users. So sometimes they are using a non-sterile syringe. Therefore, it's very important that we screen for blood donors, and we also immunize ourselves through vaccination. And since we are medtech, we are at risk of getting hepatitis B. Let me clarify my PowerPoint, ha. Vaccination or hepatitis B immune globulin is different, ha. So let's put a slash here. So vaccination is a preventive measure. Hepatitis B immune globulin could be preventive or therapeutic or prophylactic. Therapeutic because if a person is already infected with hepatitis B, then vaccination may not be useful. So that is the reason why we can give hepatitis B immune globulin. So what's the difference? Vaccination, we give antigen. Immune globulin, we give antibodies. So that's the difference, no, between vaccination and hepatitis B immune globulin. Okay, so that is the reason why, for those of you who are already candidate for internship, you are asked to be fully vaccinated before June, so that before you go to the hospital, there might be a chance, God forbids, sana hindi mangyari, that you might encounter accidental needle stick. Then at least you are protected against hepatitis B if you are already vaccinated. However, you cannot receive vaccination if you are reactive to the hepatitis B surface antigen. It's one of the markers that we will be discussing later on. So the acute infection, the symptoms of the acute infection will increase with age. So do you know that 90% of the newborns are asymptomatic? 10% of children between 1 to 5 years old will have typical symptoms, while only one-third of adolescents and adults, so mas madami yung percentage nito, it's one-third, okay, uh, will have typical symptoms. Chronic infection is dangerous because it would persist for 6 months or more, and it occurs in 90% of infected infants, 30% in young children, and 10% in adults. So the reason why I say it's dangerous because it can be complicated, and it will increase the risk of liver cirrhosis and, unfortunately, hepatocellular carcinoma. So that's why you do not want to get a chronic infection. Okay, so let's discuss the markers. So these are the markers of hepatitis B virus. So we have the hepatitis B surface antigen, okay, hepatitis B envelope antigen, and then the hepatitis B core antigen. Okay, so we also have the DNA located here, and then the DNA polymerase, which is important for viral replication. Okay, so do you know that the first marker that will occur is known as the hepatitis B surface antigen? So the incubation period is between 8 to 13 weeks, and hepatitis B surface antigen, originally known as the Australian antigen, because it was first discovered among the Aborigines in Australia. Okay, this will be the first marker that will appear between 2 weeks to 3 months. Okay, and the peak, the peak of the hepatitis B surface antigen will also coincide with the appearance of the symptoms of hepatitis. Now, after the hepatitis B surface antigen, the next marker that will occur is the hepatitis B envelope antigen. Okay? So, however, the HBC antigen is not detectable. So, this one is not detectable. Okay. So, early recovery will happen in 3 to 6 months. Okay, early recovery will happen in 3 to 6 months. And although the HBC antigen is not detectable, we can still detect antibodies against HBC antigen. So we call it anti-HBC. Okay, so there are two types of anti-HBC, no, that is detectable in this particular graph. We have the total, and then we have the IgM anti-HBC. So the IgM anti-HBC will occur first among the different antibodies, even if you are still in the acute infection. However, the peak of IgM anti-HBC will be seen at the early recovery stage. So it will peak at the early recovery stage. After which, the total anti-HBC will become steady all throughout from early recovery to full recovery. The total anti-HBC would become steady. Okay, after the IgM anti-HBC, the next marker that will appear is the anti-HBE, and it will peak during the mid-early recovery. So the anti-HBE will peak at the early recovery. Okay? And the last marker, the last antibody marker is the anti-HBS. So anti-HBS will peak at the latter part of the early recovery stage. Ito yung peak, and it will become steady. So this is the ultimate marker. If you have anti-HBS already, it is an ultimate marker that you have a successful immunization. It is also an ultimate marker that you have already fully recovered from hepatitis B. Okay? So, however, I said that 6 months is the expected period for recovery. But if you're still infected with HBS antigen, or if the HBS antigen is still detectable beyond 6 months, and the symptoms are still present beyond 6 months, what does it mean? Means that you are already in chronic hepatitis B. Is it bad? Yes. The reason why it's bad, because after 6 months and you still have hepatitis B, this would lead to liver damage. And when we say liver damage, possible complications could be cirrhosis, which could be fatal, and even cancer of the liver. And the picture would be different because here you would notice that HBS antigen and HB antigen will peak between 2 to 3 months, and it will never go down. And since it didn't go down, the symptoms will persist beyond 6 months already. Would we still develop antibodies? Yes, we would be still developing antibodies, but most of these antibodies are anti-HBC. But if you notice, there's no anti-HBS and there's no anti-HBE. And the very fact that there is no anti-HBS means that you are not yet in the road for recovery. So that's the sad part about having a chronic hepatitis B. Usually, patients with chronic hepatitis B are those patients who are immunocompromised and those patients who didn't receive the immune globulin or didn't have the therapy for hepatitis B. Okay? So take care of your liver. Okay? So take care of your liver. So let us summarize. Hepatitis virus is caused by hepatitis B is caused by hepatitis B virus, and they belong to Hepadnaviridae. So they are transmitted parenterally, sexually, and perinatal, and it can progress to chronic state. So 10 to 90% of cases may develop chronic hepatitis depending on age, with increased risk for liver cirrhosis and hepatocellular carcinoma. So serological markers are the following: HBS antigen, HB antigen, IgM anti-HBC, total anti-HBC, and total anti-HBE, and anti-HBS. And then the HBB DNA can be measured through qPCR, and this will assess the viral load as well. So clinical significance, it can cause active hepatitis B infection, And sometimes it can vary, no, with a high degree of infectivity. Okay, so, or in some cases, um, so HBS antigen can measure active hepatitis B infection. HBe antigen can measure active hepatitis B infection with high degree of infectivity. So if you're positive with IgM anti-HBC, it means that you have current or recent acute hepatitis B infection. If you're positive with total anti-HBC, means that you have current or past hepatitis B. If you are if you have if you're positive with anti-HBe, you are in the road to recovery. And the ultimate immunity to hepatitis B is uh, anti-HBs. And then the hepatitis B DNA will tell us, will assess our viral load. And it is also used to monitor the effectiveness of therapy. Okay. It can also determine atypical or occult hepatitis B. What do you mean by atypical or occult hepatitis B? So these patients are asymptomatic but positive with HBV DNA. So occult means hidden. So the person has a hidden disease. So that person could be a carrier and infectious for that matter. Okay, so that is the hepatitis B. So there are also immunoassays available for hepatitis B. And hepatitis B can be detected through PCR, traditional PCR, real-time PCR. So this one is also known as the qPCR, branch DNA, or signal amplification. So it may be a useful adjunct in detecting early acute hepatitis B infection. It is also used to evaluate the effectiveness of antiviral therapy. It is also used to diagnose atypical cases of hepatitis B and detects hepatitis B genotypes and mutations. Okay, so let us now discuss hepatitis D. Do you know that hepatitis D is also nicknamed as the pendovirus because it requires the presence of hepatitis B virus, which means that the HBV vaccine is a two-in-one vaccine because it will protect you not just against hepatitis B, but it will protect you against hepatitis D as well. Why? Because the Dane particle of hepatitis B, okay, and this particular Dane particle and also the spherical particle, these are needed by the hepatitis B virus in order to penetrate the host cells. Hence, they become dependent to hepatitis B. And hepatitis D virus or the Delta virus genus is the only member. Okay, under the Delta virus, we only have one virus, that is the hepatitis B virus. The transmission is the same as hepatitis B, the parenteral and perinatal routes. So, hepatitis B can appear as a co-infection or superinfection with hepatitis B. What's the difference between a co-infection and superinfection with hepatitis B? So co-infection means that it happens among cases of acute people with acute hepatitis B or a self-limited hepatitis B. Okay? So if a person with acute hepatitis B is infected with hepatitis D, then that is known as co-infection. And usually, the person is positive with anti-HBV. So this is the first marker. Excuse me. So the first marker, so the person is positive with anti-HBV, and the person is also positive for IgM anti-HBC. So it means it is a co-infection. Now, what is a super infection? Super infection means that a person who is a chronic hepatitis B carrier becomes positive as well with hepatitis B, then that is a super infection. So usually there is a chronic liver disease with accelerated progression to cirrhosis and liver failure. So super infection is more severe than the co-infection. So they are more severe than the co-infection. So how do we know that it is a super infection? So the person is positive for the first marker, which is the anti-HDV, and the second marker is also positive, which is the IgG anti-HBC. So ano yung difference sa co-infection? In co-infection, it was IgM, but in super infection, it is IgG. So there is another molecular marker, and this is the HDV RNA. So it is routinely used to confirm a positive anti-HDV screening. Now, if we will be looking at the clinical picture of a person with HBV, HDV co-infection, you would notice that as the hepatitis B surface marker occurs, the person, so kailangan muna ng HBs antigen so that the person could be infected with HDV RNA. Okay. And the second marker is anti-HDV IgM. Okay. So if IgM appears, then it means that there is a co-infection. The good thing about the co-infection is that eventually the HBs antigen will disappear. Hence, HDV RNA will no longer be detectable. And the presence of anti-HBs is a good marker for immunity. If you are immune to HBs hepatitis B, then you'll also be immune to hepatitis D virus. Now, this one is a sad scenario. It is the HBV and HDV super infection. Because for this particular scenario, you have a liver marker that is very high because your HBs antigen will persist, and alongside with that, the HDV RNA will persist as well, more than 6 months. So you'll have the total anti-HDV and anti-HDV IgM, and the one that is not mentioned here is the persistence of IgG anti-HBC. Okay, so this one, the second picture here is actually a sad scenario. Okay, so let's summarize. Hepatitis D virus belongs to the Delta virus. So mostly the transmission is parenteral, but it could also be sexual perinatal. And most importantly, HBV infection is required. Can it progress to a chronic state? The answer is yes. Okay. Can it increase of developing fulminant hepatitis? Yes. cirrhosis, and hepatocellular carcinoma. So there are three markers, three major markers. IgM anti-HBV will tell us if a person has acute or chronic hepatitis B. And IgG anti-HBV, it's either you have recovered from hepatitis B or you have chronic hepatitis B, depende, no? If HBs antigen is positive, and then you are also positive here, then it means that you have a chronic hepatitis B. And then just like the other, HBV RNA will tell us the viral load or the viremia level. Okay, the viremia level. And it also used to monitor the effectiveness of the therapy. Okay, so these are the different markers for hepatitis. Okay, so let us now discuss hepatitis C. Okay, so this is the last hepatitis C that we will be discussing. It is the most common blood-borne infection in the United States because before, we are not screening for hepatitis C in the blood. But now, we are already screening for it. But before we screen for it, it becomes the most common blood-borne infection in the United States and even in the Philippines. So that is the reason why it has garnered the nickname, it has gained the nickname post-transfusion hepatitis. So it has garnered the nickname post-transfusion hepatitis. It is an RNA virus with 7 genotypes, and it is transmitted by exposure to contaminated blood, sexual contact, and perinatal exposure. So most infections are asymptomatic at first, but unfortunately, it can also develop into a chronic liver disease. So again, it is a type of envelope virus. So you'd see the lipid, you'll also be able to see the nucleic acid here, and then the capsid proteins, and then the envelope proteins, which are divided into two, the E1 and the E2. So what are the markers that we can use? So we can have the anti-HCV IgG. It is the one that we are using for screening and diagnosis, which can be detected using the enzyme immunoassay or chemiluminescent assay. So we can also do the rapid immunoblot assay, yung katulad ng immunochromatographic assay, which has currently become a POCT or point of care testing. So if we're positive with anti-HCV, it may indicate current or past infection. Qualitative HCV RNA is the confirmatory test. So since it is qualitative, the manner of reporting is simply positive or negative. So we can detect it using RT-PCR or TMA. And then the quantitative molecular test is used to monitor viremia during antiviral therapy, which can be utilized using RT-PCR, real-time PCR, and branch DNA amplification. And then the genotyping, since there are 7 genotypes, this one is used to determine the best therapy and for epidemiological studies. So it is not used or not done routinely. So usually for research purposes, or if you want to develop vaccines. So genotyping would be very important. So what are the serologic patterns? So as you can see here, the presence of HCV RNA, okay, is actually the very fact that it persists for more than 6 months. Okay, since it is more than 6 months already, means that HCV could become chronic. Okay? And the ALT, which is the liver marker, however, would become unstable. So sometimes it is high, sometimes it is low. The ALT or the SGPT would be unstable. So the symptoms may disappear in less than 6 months, but it doesn't necessarily mean that you are fully recovered because of the fact that the HCV RNA could still be detectable in the blood. So the HCV RNA could still be detectable in the blood. Okay? So in summary, hepatitis C virus is a type of RNA virus, particularly coming from the Flaviviridae. Flaviviridae is the same family where dengue virus would also be from. Okay, so the transmission is parenteral, sexual, and perinatal, and it can progress to chronic state. So take note ha, 85% would develop to chronic infection. So that's why it's not good to be infected with hepatitis C. And because of the chronicity of the infection, there is an increased risk for cirrhosis, hepatocellular carcinoma, and even autoimmune manifestations. So, what are the common markers? We can use HCV, anti-HCV. Anti-HCV will detect current or past hepatitis C infection. And then the HCV RNA will detect current hepatitis C infection or the viral load, and it may also be used to monitor the effectiveness of the therapy. Okay, so that ends our discussion on hepatitis C. So let us now discuss the herpes virus infection. So we will now be discussing the herpes viridae. Okay, so under the herpes viridae, so we have the first virus that we will be discussing here is the Epstein-Barr virus. You know, there was this student and professor who discovered the virus. So it was Dr. Epstein and Yvonne Barr. So together they did research and they discovered the Epstein-Barr virus. So it is a DNA herpes virus that can cause a spectrum of diseases. And one of the diseases that is very common for Epstein-Barr virus is the infectious mononucleosis. And this one is known as the kissing disease. Okay. So infectious mononucleosis is known as the kissing disease. So it can also cause lymphoproliferative disorder, and it is associated to certain type of malignancies known as Burkitt lymphoma. If you remember the FAB classification of leukemia, so L3, acute lymphocytic leukemia or the L3, this one is related to the Epstein-Barr virus. So mostly why do we call it kissing disease? Because it is mostly commonly transmitted by intimate contact with salivary secretions. So it begins in oropharynx in B cells and epithelial cells, and it will spread through lymphoreticular system. So again, B cells would be the site of latency. B cells would be the site of latency for the Epstein-Barr virus. Okay, so